Good afternoon. Welcome to the City Club of Cleveland. My name is John Corlett. I'm the President and Executive Director of the Center for Community Solutions and a proud City Club member. I'm pleased to introduce today's speaker, the former Deputy Administrator and Director of the Center for Medicaid and Children's Health Insurance Programs Services, Cindy Mann. Ms. Mann has 30 years of experience in federal and state health policy, focused on health coverage, financing, access, and operational issues. She guides states, providers, plans, consumer organizations, and foundations on creating and implementing strategies around federal and state health reform, Medicaid, the Children's Health Insurance Program, and delivery and payment system transformation. During her time at the Center for Medicare and Medicaid Services, she led the administration of Medicaid, CHIP, and the Basic Health Program at the federal level for more than 5 years during the implementation of the Affordable Care Act. Her role included setting federal policy, supporting state program operations, and coordinating policy and program operations within the marketplace. One of the ways we know Ms. Mann was at the heart of healthcare policy making was the number of times she visited the White House between 2010 and the end of 2014, 381 times. Only 4 other people visited the White House more frequently during this time period. Right. Yeah, Michelle and Barack Obama. Mann is credited with putting policies in place that were used as guardrails for Medicaid expansion, with enrollments in both Medicaid and CHIP growing by 9.7 million since September 2013. This included approving the Metro Healthcare Plus Medicaid waiver that resulted in early Medicaid coverage for over 30,000 previously uninsured Cuyahoga County residents in 2013, a waiver that improved health outcomes, stabilized the healthcare safety net, and helped make the case on why Ohio needed to expand Medicaid statewide. She is now a partner in the law firm of Manat, Phelps and Phillips. She received her undergraduate degree from Cornell University and her law degree from the New York University School of Law. But perhaps the best title I could give Ms. Mann is the title of advocate. Throughout her career, she has always kept the needs of the most vulnerable front and center in her work. Ladies and gentlemen, members and friends of the City Club of Cleveland, please join me in welcoming Ms. Mann.
Thank you. And there's no better title, or there's no title I prefer than advocate for those who need health care and who rely on the Medicaid program. It is a pleasure to be here today at the wonderful City Club of Cleveland, and with so many people that I've worked with over the years, John, Marcia, Mary Wachtel, many of you are folks, tireless advocates on behalf of low-income families. We worked for many years trying to get to that finish line in terms of covering all eligible children. Made quite a bit of progress and a lot to be very proud of here in Ohio in the past, and as you've been implementing the Affordable Care Act over the last 5 or so years. So I suspect you don't really come to a Medicaid talk unless you have some pretty strong connections to the Medicaid program. So let me just ask, how many people here have known the Medicaid program more than 5 years in an intimate kind of way? We won't get into the details of that intimacy. So there's no follow-up question to that. You can put your hands down. So I think, you know, my premise to begin this talk is about how much change has taken place. And that's not, none of what I'm going to talk about in terms of that change is going to be new to those of you who've been living through the evolution of the Medicaid program. But I do know that all of us are really very busy on a day-to-day basis. And at any given week, in any given year, in any given month, we have an agenda. We know what we're trying to do with our organizations that we may run, with the families that we may serve. And sometimes it's time to step back and say, what has that all added up to? What are the changes that have occurred? I know that we changed eligibility. I know we did this. I know we did this. But there's really been some very fundamental changes. And as a result, when John and I were talking about this talk, we decided to call it the new Medicaid program. to really talk about how, how it has changed, not just incrementally, but really very significantly, qualitatively. So I am often fond of saying, and now that I'm a grandmother, I can really say this, that it's not your grandmother's Medicaid program. It is a really vastly different program. And I didn't ask how many people were around in 1965 when Medicaid was first established, and you don't have to raise your hand on that. But when Medicaid was first established, it really was a welfare program. So people debate now, is it not, whatever. It was a health insurance program, but it was really an add-on to getting cash assistance. If you were a family with children, or you were elderly or disabled, and you applied for cash assistance, and you were able to get through that application process, at the end of that process, if you were found eligible, you got this, I would say card, but it was never a card at that time. It was a piece of paper or whatever. And by the way, you can get some health benefits as a result. So it was an add-on. It was kind of a fringe benefit to getting through the welfare system. And being, and so as we all probably know from our history lessons, as well as from where we are today, is that welfare programs were never designed to invite people in. They were never easy to get into. The eligibility restrictions were pretty stringent. And so it had a very different philosophy. Right or wrong, you can debate it about the philosophy of running a welfare program, but very different reason of being and very different way of operating than how you think about a health insurance program. And I would argue, and give you lots of evidence for it, that what has happened over a period of time, and it wasn't just the Affordable Care Act, it really is changes starting in the 1980s and the 1990s and going through to the Affordable Care Act, is Medicaid has changed from that adjunct to a welfare system to a standalone health care program. And so much so that it is, in fact, the largest single source of insurance in this country. Okay? It is larger in numbers, in terms of numbers of people served and expenditures, than the Medicare program. Overall, more people are enrolled in coverage through their employer, through ESI, but in terms of thinking about a single program that covers people, it is the Medicaid program. And it is a very different Medicaid program than we had seen 5 years ago, 10 years ago, and certainly 50 years ago. I'll figure this out. So this is sort of a pictorial diagram of a picture of how Medicaid fits into the health insurance system in the United States right now. What the Affordable Care Act did, a lot of us will know in great detail that the Affordable Care Act created the marketplaces, it created some insurance reform, it created the premium tax credits, it expanded Medicaid, it had a maintenance of effort for children's eligibility, it did all these things. But of most significance in many respects was the fact that it attempted, even though it had these variety of programs, it attempted to pull them together so that there is now a new paradigm of coverage. Right? It said, as a matter of federal policy, people should be covered. That's a good thing, not a bad thing. That is our foundation to think about how to deliver better health care and how to put our health care system on a more sustainable financial path. When everybody is covered, we're not doing cost shifting, we're not avoiding costs and where they pop up somewhere else, but we're actually providing early preventive care, reducing unnecessary, more costly care, and trying to deliver better care, and in delivering better care, hopefully at least controlling the rate of growth, if not absolutely reducing it. So coverage is the priority, is in fact the rule of the law, a rule of law in the Affordable Care Act. And so these separate programs have been somewhat blended together, and they've been blended together so that what you get is a continuum of coverage. And that's part of the big change to the Medicaid program. It completely changed for the non-elderly, non-disabled population, the rules of how to determine eligibility. Used to have the rules literally until the Affordable Care Act. The rules for eligibility were tied to that 1965 diagram of cash assistance. If you were elderly and disabled, it was the old age, blind, and disabled that became the SSI program. And if you were not age blind and disabled, it was literally until 2014. The rules that governed eligibility were the rules from the AFDC program. There isn't even an AFDC program anymore, and Medicaid still use the AFDC program rules to determine eligibility. Complicated set of rules. The Affordable Care Act abandoned those rules and set up the same rules for determining eligibility, essentially, that are in place in the marketplace and that are also carried over to the CHIP program. And the point of that is that you have no wrong door. And the point of that is that you can begin to create a fabric of coverage, a paradigm of coverage. Not just you have Medicaid over here and you've got CHIP over here, you've got the marketplace over here, but the idea is no matter how you apply and no matter what happens to your income or your family circumstances, you get a raise and you go up over 138% of poverty, you lose a job or you have an additional member of the household and your family income goes down and your eligibility changes, you should suffer no loss of coverage. There should be a smooth transition from one coverage program to the other. So there's one application, one set of rules, and that is supposed to be the case both at the initial enrollment and at renewal, because the point really, if we're going to get to better care and lowering costs through care improvements, is we have to make sure that people who are eligible are covered and that they stay covered in whatever program they're eligible for as long as they are eligible. So big changes happened, right? We threw the remnants of the welfare system application process was thrown out. Now, there's great strides that were made between 1965, I would say actually really between 1998 and 2014 in terms of simplifying the programs. And that was so much of the work that I did with many of you here is how to simplify the programs, because we knew that the old welfare way of applying kept a lot of people out of coverage, a lot of people who were eligible. So you had long applications, you had to come with a wheelbarrow full of documents, you had to, some states get drug tested, some states get fingerprinted. That was all okay under federal law. There were no real federal rules under it with any specificity. So that all changed under the Affordable Care Act. And today, by law, not because it's a best practice, we used to have our list of best practices, but those best practices have pretty much found their way into federal law. You can't make people go to interviews, face-to-face interviews. You don't go to an interview when you apply for health insurance in any other context. And for low-income families that have the least flexibility in terms of leaving their jobs, leaving their kids, they're the least able to go down and do face-to-face interviews either at application or at renewals. So those kinds of barriers to enrollment were thrown out. Streamlined applications. I remember once a director of the CHIP program in Iowa said, you know, that Medicaid program is so stigmatized in Iowa, not in our CHIP program. I never want them to come together. And I looked at the application in Iowa for Medicaid. It was, you know, many, 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 many pages, as in like 30. And one of the first set of questions was asking all about if there was an absent parent, and when was the last time that there was any relationship with the absent parent, color of eyes, all of that. And I thought, I wonder why it's stigmatized. Is that really how we apply for health insurance? That they would never have put it on the CHIP application, but there it was on the Medicaid application. There were no federal rules about that. It was pretty much left to states. Now there are federal rules. You can ask questions on the application if they are directly relevant to the eligibility for the program. And again, it's got to be one streamlined application, no wrong door. And one of the biggest advances is data-driven verification of eligibility. No more wheelbarrow full of documents. And those same rules apply with respect to renewals. Because the point of making this all work is not just that it's nice to have people eligible, but we actually want to have people covered. And that is really the point of the Affordable Care Act is people should not just be eligible and unenrolled, people should actually be covered. So how have we done? Well, you've been doing great here in Ohio. This is data from July, from the, sort of before open enrollment, the first open enrollment, July, September 2013 to November 2015. It's data that the state sends into CMS and is reported. And what you see here, and I'm sure you all know this, is a big jump in enrollment in your Medicaid program. and an increase of about 26% of your entire Medicaid program, not just the adult category, but 26% of your entire Medicaid program. And of course, what that has meant is a reduction in the number of uninsured people in Ohio, a reduction between just in 1 year, 2013 and 2014. Because the data lag, we're going to see more changes as we get more data during this year, a 38% reduction in the number of uninsured. So if there's nothing else that you walk away with in terms of today, if you're somebody who's been, from whatever angle, you're providing services to people, you help people with enrollment, you're administering an agency, whatever else you do, whatever you do in terms of that healthcare system, step back and say, my God, in 1 year, we reduced the uninsured rate in our state by 38%. We took 4 out of 10 adults who are uninsured, and in 1 year, we gave them insurance. And that is extraordinary. That is what they often say, a historic event that we have not just witnessed, but all of us, I'm sure, had much to do with. We've seen strong results all around the country in states that have expanded coverage. And here are some facts from different states. We've seen states see a significant drop in their uncompensated care. We had this wonderful report that was done by Ascension Hospitals that have Ascension Hospital System is a Catholic hospital system that has hospitals in some expansion states and hospitals in non-expansion state. It is what my research friends call a perfect natural experiment. And what did they find? They found in the non-expansion states that uncompensated care went down to about 2.6% compared to 63% in the expansion states. We've also seen, and we've seen this in Ohio as well, states generate savings in their state budgets in terms of the expansion because they've been spending money without the benefit of federal match on certain health services as a stopgap measure. And suddenly with the Medicaid expansion, those services were able to garner federal match, and that's been a reduction in cost. There's a lot of different ways in which that has come about. We've also seen, and neighbors in Michigan have documented this well, how many additional people have gotten primary care visits. I once met with the governor in Michigan, and he came in and he said, oh God, this was a meeting with the secretary, and he said, oh, the expansion, and so many more people have enrolled than we thought would enroll. And I was like getting ready for like, okay, here's it's breaking my budget, here's the problem. And then he went on to tell us how many people had gotten mammograms, how many people had gotten primary care and preventive care visits, and was so thrilled with the fact that even more people were able to access healthcare services than they had originally projected. So we have lots of good news. You don't necessarily hear that always when you hear the sound bites about either the Medicaid expansion or the Affordable Care Act, but in fact, it is very, very consistently the experience across the states that have expanded. So that's where we've been. It's where we have been over the years and in recent times. Let's talk a little bit about what's ahead. I think I overstepped myself here. What's ahead? And forget that coverage. That shouldn't be there because it's more than coverage. So here are some key areas. There's so much on our plates. It's always you accomplish a lot. You can't just go on vacation, right? I know. There's more to do. So here are some ideas as to things I think that are still really top on the agenda. And they're not rocket science. They're all things that you're all working on. We want to make sure that everybody actually is enrolled and stays enrolled as long as they're intended. It's always nice to have things written into the laws, but it's always a little bit of a different reality when you see things actually work on the ground. So making sure that actually works. Making sure that handoff with the marketplace is working well, back and forth in both directions, that we don't lose people in between. No, there's an issue of some state law changes here and whether you're going to be faced with a Medicaid waiver. And really important is looking at delivery system reform. So I'm just going to touch on those topics so I stay within my time limit. So in terms of eligible but unenrolled, which remember, no eligible but unenrolled, right? That's our mantra. They shouldn't exist. And we've made such inroads in terms of kids, we actually know it can be done. Nationwide, our uninsured levels for children is now below 5%. And you know, we can get it even better. A couple states have actually reached about 98%, but nationwide it is less than 5%. And not long ago it was 14, 15%, right? We can bring it down. Participation rates in the Medicaid and the CHIP program have increased. That's what drove down those uninsurance rates for kids. ESI has been declining for kids just like it's been declining over the decades for adults. Medicaid and CHIP stepped in. States expanded eligibility, but beyond that, states in conjunction with community partners really made sure that those eligible but uninsured children were actually getting covered. So that's our task. Sometimes it's an outreach task. It's reaching those families, making sure they understand they're eligible. Sometimes it's a systems task, right? Where are we finding, do we know if people are able to go back and forth between the marketplace and Medicaid and CHIP smoothly? Are we losing people? Have we gotten data on that? Do we know how the renewals are working? Are we losing people at renewal, even though it should be a smooth continuous coverage? What's happening? Those are all difficult handoff points, sometimes difficult for families, sometimes difficult for the systems. Those are all areas, including just being in the community and talking to folks and making sure they know that they're eligible, where we can make sure that we get that adult uninsured number down as low as the kid number and really continue to make progress. So this is some data from the Kaiser Family Foundation and their analysis of where we are in Ohio in terms of the numbers of people. So the 834 is all people in Ohio who are still uninsured. Some of them are eligible for Medicaid. About half of them are Medicaid eligible but not enrolled. Some of them are eligible for the marketplace, and some of them are ineligible for any kind of financial assistance. So made a lot of progress, and still more work to be done. Let me talk now about changes in policy. So you have your Medicaid expansion in Ohio was adopted the way most states adopted a Medicaid expansion. So you see on this chart, on this map, all the states that have expanded are the ones in blue. Louisiana's got a little lines at the bottom because it's the new governor has announced he's expanding July 1, but they haven't gotten to July 1 yet. All the states in blue are states that have expanded. The states that have the red circles around them, the borders around them, are states that used waivers to expand, either initially or subsequently. And so Ohio is like most of the country that did the expansion, is you didn't do it through a waiver, you did it through a state plan amendment saying, and whatever other flexibilities you can take advantage of in the general Medicaid program. So we had 6 states that used waivers to expand Medicaid. We actually had an additional state, Pennsylvania, used Medicaid waiver to expand. Then the governor changed, and the new governor said, I don't want to use that waiver, drop the waiver. So there was another waiver that was approved, but it's not now in operation. We also have 2 states that had expanded, one with a waiver, one without a waiver, that now have new governors. There was talk when those governors came in about dropping the Medicaid expansion. They weren't as favorable to it as their predecessors. They have both decided since then, this is Kentucky and Arkansas, they have both decided since then that it is valuable to maintain the Medicaid expansion, but they too are going to look at either a new waiver in the case of Kentucky or some changes in the waiver in the case of Arkansas. And of course, Ohio's legislature passed some provisions that would require the state of Ohio to seek a waiver. So waivers are a way for states to seek authority from the federal government, from the Secretary of HHS in particular, to waive certain of the rules. That's where the term comes from. Instead of following Rule X or Rule Y that Congress has enacted and says, here's the law of the land, they say, I want you, Secretary, to waive that rule. Make that rule go away. I want to do something different. And here are the kinds of things that states have been doing through waivers. They have been doing some premiums, some cost sharing, health savings accounts, healthy behavior incentives, connecting to work, premium assistance, which is the Arkansas, where they're using Medicaid dollars to buy people into the marketplace product, and delivery system and payment reform. So if I look at this, I think the first 1, 2, 3, 4, 5, right? The first 5 are have something to do with the legislation also that was enacted in Ohio. Obviously, the devil is in the details. Every state is very different. These kinds of policies in one way or another have been approved, and we can go through some more detail if people want to in Q's and A's. But at the same time, the administration has drawn some very clear lines as to what will and won't be approvable. The basic standard of approving a waiver under the federal law is that it has to further the objectives of the program. Okay? So clearly different people will have different views about what the objectives of the program, but go back to that first slide. Is it a welfare program or is it a health insurance program? And that will also guide you in terms of what kinds of things this secretary anyway will or won't approve. And it's also a program that is essentially about serving people with low incomes. And to get people with low incomes affordable health insurance coverage, you need to be, first and foremost, very conscious of costs. And so, yes, there's been premiums that have been approved, but within certain clear limitations and with a clear line drawn that no premiums below 100% can result in anyone losing coverage if people don't pay those. 100% of the federal poverty line cannot afford to pay those premiums. There's also pretty clear restrictions actually under federal law with respect to cost sharing. Connecting to work, I will note, is one of those areas where the secretary, both the current secretary, Secretary Burwell, and her predecessor, Secretary Sebelius, felt very strongly that work is a good thing. No problem with the federal government and the Obama administration supporting work. It's a good thing. But is it a feature that belongs in a health insurance program? And you wouldn't, I think if you asked anybody, would you deny a child health coverage because their parents didn't work? Or maybe would you deny a child health coverage because they didn't go to school? School is a good thing, right? Parents being able to support their families is a good thing. But is it really furthering the objectives of a health insurance program that is designed to make sure that people have quality, affordable health insurance coverage? So the administration has determined that work requirements, meaning conditioning health care coverage on work, is not an acceptable feature of the Medicaid program and won't be approved through waiver, but referring people to work programs that doesn't have the repercussions of loss of coverage are okay. Things like time limits, which we had one proposal. Like welfare, maybe you should do a time limit on Medicaid, so you can only get it for 48 months. Well, no, that's not how health insurance works. Sometimes you get sick on the 49th month. And so those are the kinds of lines that have been drawn, and at least by this administration, and that I believe strongly will continue to be drawn by this administration as we move forward. Let me end with a discussion about delivery system reform, and I'm not going to do justice to it, but I know it's an area that people are really grappling with in Ohio, and it is the area to be focusing on. Obviously, we want to make sure the coverage works, but at the end of the day, the coverage meaning you actually get enrolled and you stay enrolled, but at the end of the day, it's really about getting good quality health care services. And for many of us who were advocates over the years to make sure people had coverage, for some of us, it was a real turn in the road to say, oh, really? I have to worry about how good that coverage is? I have to worry about the quality of those services? I have to worry about the integration of physical health and mental health services? That's a new world for me, many of us thought. But we're all getting there, and as we should, because it's a really important area to move forward on for so many reasons. Certainly to keep our costs in a sustainable growth rate, but really to make sure that at the end of the day, people are getting the kind of care that they should be getting. There's a lot going on around the country. I'm not going to go through details, but we have a lot of energy around the country around what's called value-based purchasing, thinking about how to change from a volume-based way of paying for health care to a more value-based way of paying for health care. Lots of debates about what that is. Many states like Ohio have used managed care, but we found often when you look under the hood of managed care, it's still paying on a fee-for-service volume basis, not necessarily driving value. So states are getting much more involved in thinking about how to work my contracting and work with my health plans and work with my providers to really change that paradigm. A lot of focus also on high needs and high cost enrollees. It is lots of attention, of course, to the newly eligible adults, but that's not where the money is, right? In every state, the money is always where people are the sickest. Makes perfect sense. People who are over 65 and those with disabilities. So thinking about, are we serving those people well? If they're going to the emergency room 5 times a month, 30 times a month sometimes, that is a sign that our healthcare system itself is sick, and what we can do to assure that they're getting better care and more appropriate settings. And an area that I know you're grappling with is improvements and integration of behavioral health. It's rare, I don't even know if I could go to a state where that isn't high on the agenda. It is hard. There are a lot of difficult issues. One of the examples pointed out here is in New Hampshire. They just got a delivery system reform waiver approved, and they're just in the throes of beginning to implement it. It is really all focused on strengthening their mental health delivery system, as well as thinking about ways to integrate that delivery system, and they're doing that on a regional basis. So there's lots of activity around the country. This gives you a sense of some of the ways in which states are moving forward in terms of some of the value-based arrangements. This is just looking at managed care, but also primary care case management. And this is looking a little bit at patient-centered medical homes and health homes. Health homes being a new feature of the Affordable Care Act, which gives you for 8 quarters of any given health home, so you can have many health homes that come in at different points of time, 90% federal match for the care coordination services. Really important opportunity to think about how to deliver better care for some of those high needs patients. So let me close with talking about really why we're all here, right? Which is, I think why we're all here, which is not just because we want to see the uninsurance rolls go down, not just because we want to see the enrollment numbers go up, but because at the end of the day, there is nothing probably more important than having good health care coverage. And it is not, as somebody I worked for was Don Berwick. I don't know how many people know Don Berwick, but really a leader in healthcare improvement. And he came to a meeting at CMS when he first started as administrator at CMS. And he asked the whole staff of CMS, what do you think is the most important thing about our healthcare system? You know, if I need a knee surgery, what's going to be most on my mind? What should I worry about? And so there's a group of, healthcare bureaucratic nerds thinking, what does he want to hear? Is it the quality of the replacement? Is it how many readmissions? Did I go follow up and have the follow-up primary care visit afterwards? Did I do all those things right? And he said, nah, it's about, I want to play tennis again, right? We don't think about like, oh my God, I really want better health care. We want to live our lives, and we want to live our lives in as healthy a way as we can. And so it struck me, this grandmother, just going back to my grandmother theme, this is Wendy, and she was interviewed for the Kaiser Family Foundation as somebody who was a newly eligible Medicaid beneficiary from Cleveland, and she personified it. She had a chronic illness, and she was uninsured, and the Medicaid expansion jumped in and really made such a difference in her life. But she didn't talk about the medicine. She didn't talk about, oh my God, now I have this great doctor. She talked about now she can be with her grandchildren and watch them grow into healthy adults. That's really why this is such an important issue and why we all care so much about it. So thank you very much for all that you do, and I think we have time for some back and forth.
Today we're enjoying a forum with Cindy Mann, partner at Manette, Phelps & Phillips, and former Deputy Administrator and Director of the Center for Medicaid and CHIP Services at the United States Center for Medicare and Medicaid Services. We're about to begin the audience question and answer period. We welcome questions from everyone, City Club members, guests, students, or those of you joining us via our webcast. If you'd like to tweet a question, please tweet it to @thecityclub, and our staff will try to work it into our program. Please make sure your questions are brief and to the point. Holding the microphones today are Director of Programming Stephanie Jansky and Marketing and Outreach Fellow Faye Walker, right there. May we have the first question, please?
Hi. Hello. Good afternoon. Welcome to Cleveland. So my question is about Michigan and the relationship between the governor and the General Assembly. Could you talk a little bit about how they worked with CMS in advancing their coverage and some of the complications that came along with it?
Okay. The governor was very interested in getting the Medicaid expansion through. The governor in Michigan is a Republican. The legislature, both branches of the legislature were Republican. There was a lot of skepticism throughout about whether to do the Medicaid expansion. And they did it very retail. The governor's office, the Medicaid agency, visited every legislator, talked to every legislator. They really walked and realized, and I'm sure it's you've all realized this as well. Often our legislators know very little about the Medicaid program. They may know about the healthcare world, they may come from the healthcare world, but often they're not very familiar with Medicaid. They've heard some things, but they don't really know it deeply. They may be more or less familiar with what it means to be living in a poverty community. So they did a lot of one-on-one, and they needed to do a lot of myth busting about what you can and can't do and so forth. So they passed legislation. It required a waiver initially from the federal government, and it also required a waiver 2 years later, which had even a greater hurdle. So I was there for the first wave. I was there for the retail work, because they would sometimes, literally, the Medicaid agency would be talking to a legislator and they'd have an idea and they'd get on the phone. Like, what do you think? Can we do that? So very real time, back and forth, and the waiver was adopted. And then the second waiver just came in. The state worked with CMS. It isn't quite what the legislature had originally proposed, which was pretty much a time limit on benefits, and then you'd have to go into the exchange or pay a lot more money, much more than what the Medicaid statute would allow for the Medicaid program. So they came to an agreement, and so far the legislature seems to think that it was a respectable balance in terms of the negotiated interests.
On one of your slides, you showed one impediment to being covered is citizenship status. Do you have any suggestions as to what can be done about that?
So it's, just to be clear, many immigrants are eligible for Medicaid or for CHIP, but certain people who have not been in the country in most circumstances for people who have been in the country for less than 5 years are barred. And then certain other categories of immigrants, including undocumented immigrants, are not eligible for the Medicaid program except for emergency services, so very limited. And what a number of communities and states have done is look at ways to finance their care. You have the anomaly of people being able to go to the hospital and they get the emergency services covered, but they won't get the primary and preventive care covered. So we have, cities like San Francisco, states like New York, that have stepped in and said, it's cost effective for everybody if we can extend that coverage in one fashion or another. So they have to cobble together, by and large, a way of doing that with state and local funds. Sometimes philanthropy, because for the most part, the federal government is not going to be able to participate financially.
Hello. In Columbus, I've been involved in a number of discussions where they're talking about skin in the game and wanting to begin to charge co-payments to these individuals. Any dialogue on that or thoughts?
So yeah, it is a recurring issue about skin in the game, and you know, my response is there's nothing inherently bad about paying a share of costs. I pay a share of costs for my health insurance. I pay a co-payment. I pay premium, and most people in this country have a deductible. My income is very different than somebody who's at 30, 40, 50, or 140% of the poverty line. And so it's not, in my view, it's not so much, is that a good idea or is that a bad idea? It's, can people afford it? Because again, the idea is to make sure people have an ongoing source of affordable quality health care coverage. Most of the reasons why people are uninsured in this country and why they were uninsured before the Affordable Care Act, now it's a lot more on immigration status, but the key reason has always been affordability, right? And so what we can't do is make health insurance, whether it's employer-based coverage or whether it's market-based coverage or whether it's Medicaid coverage, unaffordable for people, or we will be undermining the purpose of it. The Medicaid program allows co-payments for people under 100% of poverty. It allows co-payments generally at $4. There's a couple of exceptions for non-preferred drugs or non-emergency use of the emergency room. Some groups are exempt. Kids, pregnant women are exempt from that. Over 100% of poverty, there's a federal option to do even somewhat higher co-payments. And the Secretary's authority to waive the co-payment rules, because at some point Congress was very concerned about too much co-pays in the Medicaid program given the income of the population. Secretary's waiver authority is actually very constrained. So we had a program, I'd say 5 years ago, very few states used co-payments. Increasingly, states are relying on co-payments. I won't say the majority at this point, but a lot more states, because of the interest in skin in the game, people worrying about equity with other people who are paying coverage. And you know, I think my admonition is to just make sure it's affordable. And if people can afford it, that can be reasonable. And there's some waivers about it, and we, in many respects, don't know the answers to some of the results of some of the experimentation that's going on right now.
In your remarks, implicitly, Medicaid at the national level remains a welfare poverty program for the aged, blind, and disabled. Here in New York, here in Ohio, I learned when I recently moved here, the legislature eliminated the spin-down program last year. And I'm wondering, as an advocate, what might we do at the national level to deal with this national problem? And locally, if in Ohio we wanted to organize better to advocate for Medicaid, are there any states where there are good advocacy groups? I know New York has one, but I was wondering other states where advocates are well organized.
Yeah, lots of different states where I think advocates are organized. I think your point is really well taken. Let me just make two more. One is people over 65 and over were, in terms of the coverage changes, were excluded from the benefits of the Affordable Care Act. And everywhere in the statute you'll see people under age 65, blah, blah. People with disabilities, however, did get a benefit from the Affordable Care Act in the sense that you can now qualify for Medicaid if your state has expanded Medicaid up to 138% of poverty without regard to your disability status. So you may be a person with disability such that you could have qualified based on disability, but if your income is over the state's eligibility level based on the disability, you can qualify under the new adult category. So there's many people who are gaining coverage in the new adult category who have chronic illnesses or even, you know, significantly disabling conditions, but who don't qualify because the state's eligibility levels for the disabled category are because they were over those income eligibility levels. So there have been a lot of those advances, but there's, as you say, there's much more that can be done to make sure that we really have no gaps in coverage. And I do think that, you know, there are, obviously when you're 65, you can qualify for Medicare. Most people can qualify for Medicare, but as we all know, Medicaid fills in so many of the holes for the Medicare program, both in terms of cost sharing and in benefits, that if we don't have Medicaid going side by side for a low-income elderly individual, then it's often very difficult. I don't think it's an insurmountable problem. There are certainly state solutions. States have options to increase those income levels. As you noted, Ohio took advantage of an option to decrease an income eligibility level. It could be, the issue could be taken up at the federal level. It would probably likely come down to a matter of cost.
Can you give an example or examples of the behavioral health carve-in, and tell us where it didn't work and why?
Where it didn't work and why. So I think that we have lots of examples where carve-ins haven't worked and carve-outs haven't worked, right? It's, to me, the ultimate question is, can we achieve a situation where we have the services people need and there's integration between behavioral health, mental health services, substance use disorder services, and physical health services. And you can have examples of carve out and carve in where you still don't have integration, right? You know, sometimes in states that have carved it in, the physical health managed care plans have then subcontracted to a behavioral health plan. And maybe that has some benefits in terms of expertise, but I have seen that it is as disconnected and unintegrated as when it wasn't carved into managed care. So I would always keep an eye towards, is the goal integration and adequacy of services and competency of services, and what do I need given my system or where policy is going to make sure that that integration and the strength of the service space keeps highest on the agenda.
Well, first of all, it's lovely to have you here to be able to say thank you in person for all of the years you've helped Ohio make better decisions. Not always the easiest task on occasion, but thank you. I wonder if you're willing to prognosticate about the Healthy Ohio waiver. It looks from your data like all other waiver-approved states have used it to expand coverage. Are we right in thinking that Ohio would be the first waiver that would potentially constrict coverage? And if so, does that make it dead on arrival in the discussion, or is it always negotiated?
States are always free to come in with an 1115 proposal. States that haven't expanded, states that have expanded, and 1115 waivers, as you know, existed well before the issue of expansion. So I don't think that the fact that Ohio has already expanded means that the administration won't entertain a waiver proposal. Michigan did come in with a somewhat more restrictive policy in its second waiver. It was, it had a provision in the legislation that said if the waiver wasn't approved, the expansion would go away. So maybe you would think about that as it's really about maintaining the expansion in a very explicit way. We have a waiver proposal from Arizona. It would impose some additional costs on beneficiaries. The new governor in Kentucky and newish governor in Arkansas are both decided to keep their expansions but to come in with waiver proposals. So I don't think Ohio is terribly unique. It's at a very small number now, but over time, as new governors come in, new legislatures come in, they rethink. And The good news so far, from my perspective, because I'm not the least bit agnostic about the coverage, is that those governors, some of whom campaigned on getting rid of the expansion, looked at what was going on in their state, hopefully looked at what was going on in their communities and the health care of their residents, but also looked at the economics and said, well, no, I'm not going to get rid of the Medicaid expansion, but I'm going to make it my own and put some imprimatur on it. So I think that it is not dead on arrival as a theory of, I've already expanded, do I need to come in with something? That being said, I think there are very clear positives and, I think there are very clear lines that the administration has drawn, and not everything a state's going to come in with, just like Michigan, is going to necessarily be approved. The other thing I would just say, because I know you've dealt with this in your, from the last legislature, but to me it's a lesson of, both Ohio, Kentucky, Arkansas, all of the states that have seen changes in the composition either of their legislature or of their executive office, is don't underestimate the importance of cataloging and quantifying and telling the story of the benefits of it. We all get something done and it's like, phew, now what's to the next 15 things I want to get done? This is still, as you know, if you can only see how many times the Congress wants to repeal the Affordable Care Act, the issue is not gone away. And so you have a strong record here. Do not underestimate the importance of continuing to be able to document that record and tell that story. Sorry.
Hello. So when we were advocating for Medicaid expansion, one of the things we heard was we want the program to be a safety net, not a hammock. And so whether you're talking about skin in the game or you might be on the other side and talk about social determinants of health, is that the buzzword? Have you seen any innovative ways in which, in some of the waiver experiences that have already taken place, or possibly just generally with Medicaid, where you've been able to address maybe non-traditional healthcare service type of things, like either skin in the game or maybe addressing social determinants of health?
So let me just start with the hammock comment. No, it's not your original comment, which is this notion that it takes us right back to Medicaid as a welfare program. And it really takes us into a place where somehow people are poor for their own fault, and somehow giving them Medicaid will just make them even happier that they're poor. They've been happy enough, and now they're even going to be happier. Whereas the rest of America always wants to, climb up the ladder and make a little bit more, somehow if you're below 138% of poverty, you're just not one of those guys or gals. So I think, again, we've got to get out of the notion that Medicaid is somehow different than the marketplace, which provides a premium tax credit, because it recognizes that even at 139% of poverty, up to 400% of poverty, health insurance is not affordable. And so you have a sliding scale. Medicaid is part of a sliding scale subsidy system. Medicaid, CHIP, and the premium tax credit, because as people's income rises, they can pay more, and as people have lower incomes, they can pay less. And it is part of that continuum of coverage. And I think the more we can talk about that new paradigm of coverage, we can begin to have a better conversation about what policies make sense, right? And you can have a rational conversation about premiums and copays, but not because people need to be kicked in the pants, but because maybe everybody should contribute if they can afford it. So now let's look at that. Is the marketplace the right? Some people say the marketplace subsidies are not deep enough and that some people can't afford it. We know we have some cliffs in the system. Those are all real issues that I think we need to tackle. I think the social determinants of health is usually in a somewhat different conversation, at least the ones I'm in, which is a recognition that what we can do to help people like Wendy be healthy is not always what can happen at the clinic or the hospital, right? But that if she doesn't have housing, or if she's food insecure, or if whatever other situation is the case that makes it very difficult for her to live a healthy life, or to even take advantage of the health care that's there for her, that it's important that we begin to tackle some of those issues. So there's a lot of talk about it. I think we're just beginning to see some investments in that. People talk about, oh my God, people are homeless. I'm not sure everybody's willing to start funding housing. Medicaid program is not going to pay for housing. It'll pay for supportive services around housing, but not for housing. So we have to, if we're going to recognize poverty in America, we're going to have to also begin to think about tackling it. I think it's a good conversation to be had. I'm doing some work with the state of Oregon. They're certainly very focused in their community care organizations, which they created. They're regionally developed health organizations that are trying to identify and tackle what they think in their communities are the most important issues. And so the state is really encouraging them to not stick to traditional medical-only expenditures, but really think about what the individual needs. Obviously, there's some limits on that. So I think we're going to see a lot more over the next 3, 4, 5 years in terms of actually hitting the ground. A lot of planning going on.
Today at the City Club, we've been enjoying a forum with Cindy Mann, the partner at Manette, Phelps & Phillips, and former Deputy Administrator and Director of the Center for Medicaid and CHIP Services at the United States Centers for Medicare and Medicaid Services. Special thanks to our table sponsors today, the Cleveland Clinic, the Positive Education Program, the Center for Community Solutions, and the Centers for Families and Children. Thank you, Ms. Mann. Thank you, ladies and gentlemen. This forum is now adjourned.
For information on upcoming speakers or for podcasts of the City Club, go to cityclub.org.